right, so case number 2, please, if you can load that. So what you're going to notice is in glaucoma, there's no consensus, and so you're going to, I guess what we're going to have is Dr. Parrish answer last, because it's so hard to disagree with Dr. Parrish. Okay, next slide up, please. So this is a case with high IOP and allergies. These are my financial disclosures, some of which are relevant to the discussion today, but they don't influence anything that I've done. It's an 84-year-old woman of European descent, sent to me by another glaucoma specialist for evaluation, high blood pressure, kidney disease, and hyperthyroidism. She has wet AMDs, receiving multiple Avastin injections, PCIOLs, OU. She's on natarcetyl and timolol. She's allergic to everything, and sulfa meds, and this is what she looks like. And she has asymmetric disease, and you can see on the right there's some visual field dysfunction. Just for the panel, I'll actually start with Dr. Parrish. Do you think patients can be allergic to all drops in this kind of situation, or how do you handle this?
Well, I think it really begins and ends with the term, quote, allergic. I mean, is it biologically plausible to think that a medicine in the category as an alpha-2 agonist versus a beta blocker versus a prostaglandin analog have anything in common that would lead to this? I mean, it doesn't make sense. I think we use allergy in many ways to explain a toxic effect to whether it's benzalkonium chloride or some of the other diluents. I mean, it's always been difficult for me to figure out how 3 different drops all cause the same problem when it doesn't make sense biologically.
Okay. Can we go back to the slides, please? Okay. So this is what she looked like on exam. She had some, her vision's there. Her pressures were 33 in the right and 50 in the left. Corneal hysteresis were average. Corneal thickness roughly average. She had this mixed papillary follicular reaction and a lot of changes in her macula consistent with macular degeneration, but decent nerves. And so, Joe, what would you do next? Would you add Dimox, even though she said she had a sulfur allergy? Would you add some steroids? Would you stop everything? Or would you send to another glaucoma doc?
I'd send to you, Devinder. Now, this is a tough case, and I think we see more and more of this as patients are living longer. I mean, life expectancy is totally changing the way we have to treat this disease. And though this person is 84 with relatively decent fields and decent RNFL, it looks like, they're receiving repeated injections, and those pressures are real. This patient's at risk for a vascular event. I think you have to get the patient's pressure down. And I think sometimes, even though you're looking at the ocular surface and thinking, is this an eye I really want to operate on? I think sometimes you have to do it. I mean, we'll try to get the surface in better shape, but I think this patient's going to need some surgical intervention.
Okay, can we have the slides again, please? Okay, and so what I did was I stopped the natarcetyl, decreased the timolol to once a day, added lodiprednol, said come back in 2 days, and her pressures were 33 and 47. So then I thought, well, let me add back on the latanoprost, and this is what she did. Upper picture is what she looked like when I first saw her. The lower picture is what I did to her, and her pressure was 33 and 47. So my work is done here, and I felt like a champ. I was like, okay, all right, next case. No, I'm kidding. All right, so the question is really, what do you do next? And we're getting to surgery. So, Jack, what would you consider in this type of patient?
So, I like your approach, actually. I probably would have stopped a lot of the medicines and tried to calm the eye down, because whatever surgical approach you're going to take, you'd like a more calmed down eye. And unfortunately, with the ROCK kinase inhibitors, we're seeing some of this. We're seeing these really hot eyes, especially early on. A lot of them get better in days to weeks, but we're seeing them. And so we got to back off that some. I probably would have done, in your choices earlier, I would have stopped all drops, put them on some sort of steroid, and considered the Dimox. I don't know what the sulfa allergy really was. Was it real sulfa, or just they were sensitive to something? And think about using that to temporize. But then I think surgical intervention is, and it looks like a fairly healthy nerve and a pretty decent field. So you've got everything at your disposal. Yeah. I think probably depends on on where you go in terms of MIGS or not. She probably, at 84 with these nerves, does not need a pressure of 10. You know, if you take her from 50 to 20, that may be enough, and so maybe this is a really nice space for MIGS.
Okay. All right, can we have the slides again, please? Okay, so I think this is going to be the audience response. So what would be the plan? Would you consider a MIGS? Would you consider a trab, a tube, a GAT, or a XEN gel stent?
Devendra, you may have mentioned it. How often is this patient requiring injections?
It's pretty active. She's getting active injections.
In both eyes?
I think it was the right eye, the left eye first. There it is.
That is a perfect response.
All right, and that, ladies and gentlemen, is glaucoma, and that's going to be basically the response there. Okay, slides, please. Okay, so you know the challenging part about this patient is, you know, would you do both eyes on the same day? A few days apart, a few weeks apart, you know, which eye would you do first? The pressure's 33, 47. Pradeep, what do you think?
I don't think you're in a huge rush. You know, I think, and the nice thing is that you have so many options here, and if you're a surgeon who's comfortable with more than one of these, which I think many of us are, try one, give it 2-3 weeks to see whether you're getting good trajectory and good response.
Yeah.
And then move on to the other one. A pressure of 33 with a 0.65 cup.
Yeah.
Even in an 84-year-old, she's going to survive a couple months.
Scott, what do you feel comfortable doing a trab or a tube a week apart, 2 weeks apart, 3 weeks apart?
I say I am always humbled by my surgical outcomes. As good as I think or enjoy what I do, I think surgery always humbles me, and so I really still enjoy getting a patient stable and quiet before I go on to the second can of worms that I may open. And so I am not at all eager, especially in this case, to jump into the second eye that soon. I have to agree, like 0.65 cup with a pressure of 30, she's going to be okay for a while. Yeah.
Okay. Can we have the slides again, please? Okay. So what I did was I actually moved forward with the XEN in the left eye. 30, I agree with Pradeep. 30, I don't feel as pressed, but when the pressure's up in the 40s, high 40s, I don't like that. And so I moved forward with the XEN just to get her down immediately, and I wanted to really, I knew she was not able to tolerate drops well, whether this is a true allergy or just the whole surface is irritated. And so, on first week, her pressure in the right eye was 30, left eye was 8. In the right eye, she was only still able to tolerate the timolol. And so we kind of touched a little bit on this as well. Tosi, what would you do for the fellow eye?
Well, at this point, I could possibly repeat the XEN, do a XEN in the other eye. Hopefully, you'll get the same outcome, or you can do an angle-based procedure. I could do a GAT in this patient.
Yeah. All right. And okay, so what I did actually, I just given the whole surface of the eye and the stage of that patient, and she had transportation issues as well, I wanted to just get both eyes done. And because her left eye did so well, 14 days later, I did a XEN in the right eye, topical again, ab interno, with 60 micrograms of mitomycin C. And on post-op day 8 on the right and 22 on the left, her visions were slightly improving, probably from the surface. And her pressures were down to 14 and 13, and she was still on some aggressive meds. On post-op month 3.5 on the right and 4 on the left, her vision was still pretty stable. Her pressures were slowly creeping up, which is what you can see with XEN. And she was on steroids once a day. And so I stopped the steroids, I restarted timolol, and saw her just last couple weeks ago. And she was about 11 months out on the right and 11.5 on the left. Vision actually improved. Pressure still in the 13s, which again is probably beyond what we need based on the nerves, but I'm not complaining with this lady. And this is what her left eye looked like. You see this low, diffuse posterior kind of bleb, much healthier appearing conj in both eyes. This is her right eye, and you can really see this a nice example. And this is kind of a before and after of what she looked like. And this is actually not too much after her surgery. So, as you can see, there's no consensus in glaucoma. I don't think there is a right answer. We're learning, and every patient teaches us. Drops can cause a lot of irritation. My personal bias is whenever the eye is irritated, everything will irritate it more. And so, you know, and also in certain situations, I always have to ask myself, what surgery do you feel most comfortable doing in rapid succession if you need to, back to back? All right. Oh, thank you guys for that case. All right.